Hi, Mike Gibson, Sem Rikken, and we're talking about two new agents, selatogrel, a P2Y12 inhibitor that's given subcutaneously, and a new 2B3A inhibitor, zalunfiban, also given subcutaneously. Two different mechanisms of action here. A P2Y12 inhibitor blocks platelet activation. A 2B3 inhibitor blocks the final step of aggregation. Doesn't matter how you made the platelet angry, it blocks that final step of aggregation. And you have done a study comparing the two in terms of their PK/PD. Tell us a little bit about what you found.
Well, thank you for the introduction, Mike. So we did a comparison between two novel antiplatelet drugs currently in phase 3 clinical trials, zalunfiban and selatogrel. And basically, what we did is we took blood samples from healthy donors not taking aspirin. We anticoagulated those with PPEG, a thrombin inhibitor. And then we in vitro edited concentrations that were used in the clinical phase 2 trials. And then we use light transmission aggregometry, so the gold standard for platelet function testing, to measure the response of both drugs in response to thrombin, a potent platelet agonist, and ADP, another potent platelet agonist.
So, what did you find?
So we found that when we stimulated the platelets with ADP, zalunfiban and selatogrel were both equally effective in inhibiting platelet aggregation. But when we stimulated with TRAP, so a thrombin mimic, we found that zalunfiban was a more potent inhibitor of TRAP-induced platelet aggregation compared to selatogrel. And this finding may carry important information, as zalunfiban may provide greater protection against thrombin formation. As thrombin is the most potent primary platelet activator, produced within seconds after vascular injury, this may carry relevant information if those drugs are administered in the pre-hospital setting to limit thrombus growth.
Yes, Sam, we've known this for quite a while about all the orals. So, whether it's prasugrel, ticagrelor, or clopidogrel, they don't block platelet aggregation to the most potent stimulus, thrombin. We've known that for since the development of these drugs, and this shows that yet again for this subcutaneous form. It doesn't surprise anyone. Again, this really works through the ADP mechanisms, not through thrombin. So, very important observations. Some You've also reported some data looking at a dose response to zalunfiban in terms of flow and patency in the setting of heart attack. Tell us a little bit about those results.
Yeah, so we did a post-hoc analysis of the phase 2A study in which three escalating doses of zalunfiban were tested in patients with ST elevation myocardial infarction. And we looked at that study, and I have to say, zalunfiban was administered at the cardiac catheterization lab, so not pre-hospital, as is now being tested in the phase 3 trial. But in the phase 2 study, we looked whether when zalunfiban was administered at the cath lab, whether pre-procedural patency was improved. And we also looked at the myocardial perfusion grade, as well as thrombus grade. And what we found was that the higher doses of zalunfiban were associated with more frequently actinic flow grade 3 pre-procedural, so pre-PCI. We found the same parallel trend when we looked at myocardial perfusion grade, and we found an inverse trend with the thrombus grade. So the patients that received the lowest dose of zalunfiban, the highest thrombus grade PPCI, and the patient that received the highest dose of zalunfiban, the lower thrombus grade. So this is a really important finding.
Yeah, I think it's important to link these two. I mean, you did your PK/PD work, kind of test tube data, but then clinically in patients, you have seen that better blocking of clot follows a dose response, and higher doses give you less clot in humans having a heart attack and better flow. So nice to see the kind of bench to bedside kind of results. Exciting to see this tested out in a phase 3 trial now of STEMI patients. So thank you for joining us today, and thanks to all of you for joining us here from ESC 2023.